Good afternoon, and thank you for sticking with us. I know this is the last session of the day, although we encourage you to come to the reception afterwards. So this is the session for care coordination for special populations, and I'm going to let Joy introduce herself. So thank you very much for coming this afternoon.
Thank you. Okay, I'm failing at the microphone here. Okay, so thank you for sticking it out. I think that I've been encouraged sort of throughout the day to hear similar things that I was going to say from the morning session, afternoon sessions. And at some point, we're going to have, in a couple of slides, have the microphone come around because we're a small enough group. And I'd like to hear where you're from, and I have a couple of questions for you. So just a little bit about myself. My name is Joy Twesigye. I'm a nurse practitioner, and I work for the National Assembly on School-Based Healthcare. We will we're going to roll out a new brand. We're going to be the School-Based Health Alliance. We're going to have a new logo. It's going to be very exciting. And our conference is at the end of the month. It starts on the 23rd in DC. And so I was asked to come and talk to y'all because we are one of the national, cooperative agreements, and we sort of have a long history. We provide services for children in schools, and you provide services for where people live, and so often the students who we serve are also in public housing. I have kind of a history of doing case management, of care coordination, hospital-based and community-based. Hospital-based, I'll talk a little bit about it later, but I was lucky in which I was tied with a family practice out in the community, so it was a lot of care across the continuum of hospital and outpatient and making sure I didn't see people that frequently in the hospital. And then I've been doing some community-based work for about 20 years around perinatal mood disorders, new family support, things like that. And so I'm one of the state coordinators for Postpartum Support International, in which I do care coordination around perinatal mood disorders for the state of Maryland. So I came here assuming that maybe y'all didn't know about what we do at NASBHC, and so we have, basically 3 buckets of what we do in terms of advocacy. We advocate for things like the patient-centered medical home, for CHIP, for Medicaid, for different programs, and for the fundings of that, of the programs that we advocate for. And then in terms of the training and technical assistance, I'm the associate director of the Programs and Professional Services arm. So a lot of the work that I do is in that sort of category. We do webinars, mainly throughout the school year. We have different series, so grand rounds. We do a series around patient-centered medical home and a series around sustainability. We've got plenty of free online content, and then we also do some consultative work. And then we're a membership organization, so feel free to become a member if you were so inspired. $75 is an individual and an organizational membership for $500. And I should point out that our clinics, we have 2,000 across the country. They are created from the community. The community decides that this is something that they need, that they see that their kids are having problems, whether it's attendance, whether it's asthma or whatever, and they come to us and they say, hey, can you help us start a school-based health center? And so a lot of the organizations that sponsor school-based health centers are, federally qualified health centers, hospitals, where they're funding out of the community benefit, nonprofits, et cetera. Okay, so the objectives today are that you're going to learn 3 effective mechanisms for care coordination. We're going to talk about, how to assess and manage common obstacles for providing care coordination in special populations, although I'm sure y'all have plenty to share with the group. And we're going to describe some health disparities and some social determinants of health that impact special populations. And so here is where we begin the sharing and caring, where we're going to go around the room, and I'd like for you to tell me your name, your position, your organization, and I specifically want to know whether you have a system to track referrals, whether it's written or whether it isn't, or if you do care coordination. So it looks like you have been nominated to begin.
and I'm the president on the LRC.
Thank you.
I'm Chad Rohr. I'm a service coordinator at Columbine Homes here in Denver Housing Authority. I work with families, and about half families have elderly disabled.
And do you do any written protocols or anything like that?
No, I mean, we just do kind of our basic case management. We don't, like, specifically with special pops, you know.
Okay.
We don't really
All
do
right.
too much there.
Okay.
I'm Corey Peltz. I'm also with Denver Housing Authority. I am in the Sun Valley neighborhood service coordinator, so we do coordination of services.
All right.
I am Taronda. I'm a service coordinator at Denver Housing Authority at Mount View Elliott, and I work with the senior and disabled population.
I'm Lisa Durkin. I'm the Deputy Executive Director at United Neighborhood Centers in Scranton, Pennsylvania. We're a multi-service social service organization, and we're looking to make the connection between healthcare and human services.
Hi, my name is Liberty Day, and I'm a Senior Project Manager at Health Outreach Partners. We're also one of the national cooperative agreements. I don't currently do care coordination, but I have in the past.
Hi, my name is Rena Ramirez. I am a medical director at Suffolk Health Center in New Jersey. We do have a system to track referrals, and it is written. We do care coordination through patient-centered medical home care coordinators as well as patient navigators, and we have those written as well.
Great. Thank you.
Hi, my name is John Kane. I'm with the Boston Housing Authority. So we're a housing provider, not a health center. There's one program that we do called Breathe Easy. If somebody goes into a health clinic and they're having a hard time breathing, the doctor can do, you know, what they do, but they've added a few questions. We'll ask also about their home environment. So sometimes we do get a referral that way, and so that way we can kind of take the healthcare home and see if there's something that's happening at the home that could be impacting their health, and that is tracked.
Great. Thank you. Thanks for sharing.
My name is Gail Van Loan. I'm a resident at Quig Newton Homes, and I am Vice Chairman of the Consumer Advisory Board for the Coalition for the Homeless.
My name is Clara Enriquez, and I'm a case manager for the Colorado Coalition for the Homeless at La Casa Health Center. We work with the Quig Newton public housing residents and also with Sunnyside neighborhood.
Hello, my name is Diana Ray, and I'm a case manager. I work for the Colorado Coalition for the Homeless. I've worked for the coalition for about 15 years. I'm a former resident of public housing at Quig Newton. I was hired as an outreach worker / medical assistant, and what else did I say? I work with the coalition. Did I say that? I love what I do, and that's what you got to do. You got to love what you do, and I said I've been there for 15 years, and I just love it.
Oh, that's all right. I've always been left behind anyhow, so what's the difference? I live at North Lincoln Mid-Rise. I am vice president of the LRC. My name is Ann Freeman. I work with everybody there in the building. I help everybody if I possibly can.
Great.
Okay?
Yes, thank you. Thanks for sharing.
Good afternoon. My name is Eugenia Smith. I am the chairperson for the Community Committee for Health Promotion in Boston, Massachusetts, under the auspices of the Prevention Research Center.
Hi, I'm Teresa Pfaff. I am a public health nurse, and I'm affiliated with Johns Hopkins University School of Nursing. And we have 3 nurse-run centers that are run through a service learning cooperative amongst the different schools. And we do various different referrals and care coordination. However, some of it's more formal and other parts are more informal.
Good afternoon. I'm Karen Parker, and I'm Special Programs Officer at a community health center in Alabama. This is Wardrick Griffin. He's our Special Program Site Manager at the same center. We do have referral systems in place. They are written. Also, we are in the process of working on becoming accredited as a patient-centered medical home, which I think will truly embody more of what the care coordination portion is all about, which is why we wanted to attend this afternoon. So thank you.
Great, thank you.
Hi, I'm Pam Hawkins with the Akron Metropolitan Housing Authority, and we do service coordination. We do have a strategic plan, protocol, and a work plan to go with that.
Great.
I'm Barbie Baker with the Oklahoma City Housing Authority. I'm the Assistant Director of Public Housing for Senior Housing. And we also have service coordinators and a lot of informal referring.
Hi, my name is Emily Oak. I'm the Special Populations and Outreach Coordinator for the Arizona Primary Care Association. So we do all the training and technical support for all the FQHCs and lookalikes in Arizona.
Great.
Good afternoon. I'm Dara Hesse. I'm a program officer with the Colorado Health Foundation, and we invest in organizations that do care coordination.
Good afternoon. I'm Ann Holthouse, and I am a nursing instructor, University of Colorado College of Nursing. And so we're looking for places for students to go out and do service learning projects as their public health nursing course.
Great. Did everyone hear that from Colorado? She's looking for sites for her students.
Hello, my name is Albert Chavez, and I'm LRC president for TAPEACE.
Hello, my name is Patricia Garcia. I'm the secretary from TAPEACE too.
Rodriguez. I'm the secretary of Casa Loma Senior Building and for Denver Housing.
I'm George May Waddell. I'm the president of Casa Loma.
Great. Well, thank you, everyone, for sharing, and I hope that you get some ideas now that you know who else is in the room of who you might want to work with or talk to in the networking session afterwards. I think many of us think about care coordination as prevention. You know, we work in the safety net, so we're trying to prevent as many people fall through the cracks. I think that's why we all come to work, and care coordination and case management is one of the ways in which we can do that. And like I said earlier, what I think is sort of unique about what you do and what we do out in the schools is that we're actually bringing the services to people. People feel like they're isolated, that they're sort of in this desert, and we're saying, okay, this is where you live, these are the services that you need, we're gonna bring them to you. So we're gonna try to reduce as many barriers as possible. So I know that there's been a lot of talk about health reform and care coordination throughout the day, but I'll just touch on these items a little bit here in terms of, there are opportunities for some reimbursement, whether it's with the patient-centered medical home in terms of that additional payment of that PMPM. There are potential ways of payment in terms of community health workers, if that gets funded. So there are opportunities here. Everyone is talking about care coordination. We go to a lot of meetings. At our organization, Aetna has actually funded some research around care coordination and the safety net, and so we have our research director kind of going through some school-based health centers and seeing what's currently done, what's the lay of the land, what are sort of some best practices, and how can we make things better. There's this push for a population-based system, and I'll talk about opportunities in which care coordination can actually show up in public health outcomes, so that it's not that, we think, well, this is the right thing to do, this is what we should do, the people are here, but we also need to share with the people who write our checks that, this is how we're showing up in the health system in health outcomes. So we'll talk about a little bit later in terms of meaningful use and some of the other quality measures in which care coordination can impact. So here are some health outcomes that are like low-hanging fruit for us to help with. So care coordination, the research says that, it reduces mortality with heart failure. You will be able to see that if you have people who are able to come down to your clinic, weigh themselves every day, or if you're able to go and check on them, check and see what their logs are, or just go to their house and, to their apartment and weigh them. And heart failure is one of those ways in which you can frequently end up in the hospital. And so it's a really sort of direct way to impact people's immediate care. Again, care coordination reduces mortality and dependency in terms of stroke. When people know that you're there, they're able to come to you, Susie doesn't look quite right. You're already there, you're seeing them, you can see that something has happened, that there are changes, and we know that there's a really short period of time in which we need to get people to care, and so you're right there to help facilitate that. Also in terms of symptoms with depression and at the end of life, and like I said, I do a lot of care coordination around perinatal mood disorders and about postpartum depression, and I just did a training this past weekend with some doulas who were working with Healthy Start around, a lot of their moms, they do all these like follow-up programs, and a lot of the moms won't leave the house. They send vans out to come and pick them up, to bring them to their case manager, but they won't come. They don't answer the door. They won't come to the case managers, and the case managers in Baltimore are not going to them. And so in the training, we sort of talked about, you're in this really great, you're building this great relationship with these moms throughout their pregnancy. They're gonna trust you, and here are these ways that you can have these tools, these screening tools, so that they'll open the door for you after they have the baby, and hopefully you'll be able to get the services to them or get them to come out of the door to the services. And then again, care coordination is showed to improve glycemic control with diabetes. My father has diabetes, and let me tell you, he is great. Not that he's here, but he's a great human being. But they had all the diabetic training, as he would. He ended up being diagnosed because he went into the emergency room and he ended up in the ICU. And he had a really great nurse educator in the hospital, and she did all of the training, and I tried to explain to them, he's got this tremor though, so when he's gonna go home and try to check that blood sugar, this isn't gonna work so great. And so they thought that they found him a machine that would work okay, but it was because I was able to be there to make sure for the next 2 months that he was successful. We swapped out different devices, and it's a lot of encouragement when somebody is a new diagnosis, and you're there and you're able to provide that support. So the research also says that, again, with a heart failure, you reduce hospitalizations, and so I recommend that you could collect this data and then go to your local hospital and say, look at all of the wonderful things that I do for you. Would you like to write me a check? Because a lot of what we do, even if it can be reimbursed, a lot of what we do, it's it's not enough. A lot of the services that you provide, that we provide, sometimes are really high intense services. And we have an example of a clinic, and it's actually about 12 clinics in Baton Rouge, where that's exactly what they did. They're school-based clinics, and they tracked their kids with asthma, and they worked with their Medicaid HMO, and they were able to figure out what is the cost in terms of the HMO paying out in terms of ER visits, and then they were able to do a care coordination program, and then they were able to show the savings that they provided with a Medicaid HMO, and then they went to the hospital, and the hospital was so excited and wrote them a check. And then they built that relationship, and the hospital became even more excited, and now they have a more permanent relationship because they were really able to show the benefits that they were providing. They're able to show their outcomes. in addition to the cost savings. And then again, there are the readmissions that can be decreased in terms of mental health conditions, which I think is really important because, as we all know, it's not like there are all sorts of places to access inpatient mental health services. So anything that we can do in the community, I think, is really important. And again, it's cost effective when applied to treatment of depression. So there are a lot of definitions of care coordination, and I was going to put a whole bunch of them up there, but then one of my colleagues was like, why don't you just make a Wordle of the definitions? And so I put all these different definitions into the computer, and this is sort of what pops out, right? So care is the biggest word that sort of follows all the different definitions, and patient and services. And it's really interesting that teamwork doesn't pop up, because I will make an argument that teamwork should be the cornerstone of any definition of care coordination. I mean, there's like participants is in there, and there's, you know, some active words, but, you know, and delivery is there, but you know, teamwork is really essential. You have to partner with the people, with your patients, with the people that you serve, but you really have to partner with the other services with the other organizations that you're trying to work with. Otherwise, it doesn't really work. But I did put this wordy slide up about what the Agency for Healthcare Research and Quality, how it defines care coordination, because I thought it was good. It'll be up there. You can download it later. It's not, you know, super thrilling. But I did think that it was the most comprehensive definition, and I thought that it really addressed the different levels of teamwork and active management. So care coordination requires a team. So as I said, I used to do care coordination within a hospital, and this is most of my team that were in the care coordination department. And we were in a safety net hospital. We were Ohio State, OSU East, so Ohio State bought a community hospital. And so we were really fortunate that we had a social worker on staff, that most of us, I guess we had 2 social workers and the rest of us were nurses. What I really enjoyed about this was, like I said earlier, that I was paired with family practice physicians that were part of the Ohio State system, and in particular, the resident system, and so that I really could make the connection, and I wasn't just sort of this discharge process. I had access to their records outside of the hospital. I could, you know, if we signed them up for free insulin services, they could come pick them up. I could follow up with them. I lived in the community so that I could see them otherwise, and you know, it really worked out. So I want to sort of talk about care coordination in terms of three general approaches. In real life, I think that the approaches are a little bit more muddied, but I was reading different research articles, and even though the different research articles called them different things, they all generally came up with these 3 different categories. So there's this system sector based service integration, and with the system sector, this is really like care coordination across agencies that have to do with a geographic location. So it's sort of what I do with Postpartum Support International. I'm doing the care coordination for the whole state. You can do care coordination for the city. It's really sort of geographic based. And then the agency based is really focused on integrating these services. So this is like a Kaiser model, where we're gonna have the dental services, we're gonna have, whatever specialist services. This is what some of our school-based health centers look like. Some of them are, primary care only. Some of them have primary care mental health. Some of them have whole dental suites. And then some of them also provide, vision services. So again, it's all about decreasing the barriers to care and bringing them right there where you are, so that people just have to walk into a different door. And then there's the client family-based service care coordination, which I think a lot of us are familiar with. This is, somebody comes into our office or gives us a call and they need something, and we're dealing with people, family, one-on-one, connecting them with the services that they need throughout the city. So one of the mechanisms, and I'll talk about, I think, 3 mechanisms, the mechanisms of care coordination in general about service planning. So at the beginning, you want to sort of develop a joint action plan. You want to figure out who's going to perform the administrative work and who's going to be the person out there beating the pavement, calling people, nicely cajoling people into doing whatever it is that you want to do, right? And sometimes it's the same person, and sometimes they're two separate people. Or the administrative person becomes the computer, and then you just leave the one person to do all of the relationship work. You have to do the planning to ensure consistency and access to services so that people don't feel, so that your clients don't feel like, well, you know, these 3 people were able to get into this program and these other people weren't able to get in this program, and whether it's because not everybody on staff knows what all the programs are available or just the communication is inconsistent, but it's really important to make sure that there's consistency across the board in terms of access to the services. And then there's just, you know, doing sort of an environmental scan of what do your clients need and what's available and what's not available, and then trying to fill in the gaps. So the administrative functions, you know, you've got to set an eligibility criteria, and I've heard throughout the day that it sounds like some people, you know, you meet, there's a crisis level, whether, you know, it's a mental health crisis or there's some sort of criteria in which then there's like case management happens, or whether you're going to do care coordination for everybody, but you have to decide what can you do within your organization. And then there's resource allocation in terms of, you know, which programs are free, which programs are covered by Medicaid or Medicare, which programs are grant funded. You have to sort of figure all of that out. And then when, if you're running a program, you know, when does somebody, you know, meet that graduation level? Or, you know, is it that after 3 or 4 months, their diabetes has been well managed, and you're like, good job, Helen, I'll come back and see you in another 3 months or another month, instead of doing more active work. You have to decide that amongst yourselves. And then that's sort of in terms of the determining magnitude of need, you know, how much intensity do you need to give people? And then again, sharing needs across the system. So the client-specific service delivery. Again, you've got to make these referrals. A lot of what our staff does in the clinics is not only does, you know, we're dealing with children oftentimes. Sometimes, you know, they're older, they're teenagers, so they can do some of these things themselves, but okay, I'll talk a little bit about this later, where we did this oral health work. You know, there was a clinic here in Colorado where there was a kid who had a really terrible abscess, and so it's not just I'm going to make the referral, I'm going to have to call the parent. And then, okay, well, I've called the parent to let them know about the abscess, but then we have to get across the mountain range because the parent doesn't have a car. So then it turns into, you know, this woman who's working the school-based health center, putting the kid in the car, but before she even gets to the car, she has to call around to find somebody who does pediatric dental work, which, you know, isn't super common, and that will take this child because it's an emergency. And then she drives him over the mountain pass so that he gets services. So it's, you know, can become time-consuming, a little complicated. And then, you know, ensuring accessibility, making sure that people have an individualized plan, because we all know that everyone is an individual. So even when we're talking about population health, we can't forget that what motivates people is an individualized plan. And I think that there was a good role modeling earlier this morning about how can you figure out what people are willing or ready to do. You know, is it that they are okay to go to the gym for, you know, 10 minutes a day versus just like everyone should have, you know, an hour's worth of activity, and so you should too, whether or not they're ready for that. And then you have to monitor and that plan that you came up with is working, and if it's not working, then you have to change it up. So we didn't get into like a flat-out fight in my office about this, but we definitely had different ideas. I think just different perspectives of care coordination versus case management. And it was, it's interesting, and I think part of it is because there's so many definitions and people use the terms interchangeably. And like I said, we're doing a research project around care coordination, but whatever. This is, because I'm here, I get to share what we sort of decided in the office before I came out here. So this is how I'm sort of going to talk about the difference between care coordination and case management. So care coordination, if you think of yourself as a nurse who's working, on a regular floor, she's got 6 patients, we'll pretend, and it's a good day, and she's got 6 patients, and her job is to coordinate care for all of her patients, right? She has to make sure that everyone has their lab drawn, that, if you were supposed to go to the x-ray and then come back, that you did, that if somebody was supposed to go get a colonoscopy and come back, there are all these different individualized plans, and that's her job, is to make sure that all of those things get done, and then communicate sort of the outcome to the patient and to the physicians and everybody else who cares. And then in terms of the ICU nurse, something's happened, right, for you to end up in the ICU. Whether your diabetes is more out of control, whether you've fallen into coma, whatever it is, you've hit some sort of criteria, you've triggered something that requires more intensive services. So she still has more than 1 patient, maybe she has 3, and her job is to still coordinate the care and make sure that you get the labs, drawn or whatever. But she's doing more intensive services, she's following things more closely, maybe there are actual procedures going on into the room. It's just a higher level of service. This could be different depending. I know a lot of places you're only doing case management, and case management is sort of synonymous with care coordination because for a lot of people, everyone is sort of really sick, and so you're trying to figure out, okay, well, we're going to put asthma people in this, category, and people who have diabetes or people who have high blood pressure, but you're really providing intensive services to everybody. So that was sort of why we had this debate in our office. But I would sort of think about, because I know that there have been some questions throughout the day about sort of a focus on people who are older, is that you have the opportunity to provide some care coordination, some case management for people across the lifespan. So and I know that these small children are not getting the prenatal care, but whether it's about the prenatal care, whether it's about asthma in children, especially asthma, because a lot of the interventions are in the home. So if you feel like, there's a whole family that's suffering from asthma, if there's just one, that you're in a good place to either enroll the child in several programs. I know in Baltimore, with one of our school-based health centers, they make a referral to a program that's out of Johns Hopkins, where then they go to the students' homes and they help them get a new mattress, get a new vacuum cleaner with a HEPA filter. They do all of those services in the homes because that's where the intervention really needs to be. So our oral health, NASBHC has been doing a lot of care coordination projects, and our oral health project didn't start as a care coordination project. We were funded to train primary care providers on how to do oral health assessments and how to apply varnish, and then to make referrals to dentists. But what it turned into was we did the training, we did follow-up stuff, and all of our real problems in terms of the project had to do with care coordination. A lot of the clinics hadn't really done it before. They didn't have a mechanism. They would make referrals. They weren't really sure if Johnny ever went. So unless something was really acute in which people were really attentive and following up, they were just having a really hard time. And we weren't expecting that, and we thought that we weren't expecting it, so we learned a lot. We had 40 grantees, and some of these grantees had multiple sites. And so this is sort of what our lessons learned with it, was that we had to assess the clinic capacity for being able to do care coordination. And that we also learned that having sort of, everything's very relationship-based, which we've talked about, and people might know what to do, but if it's not written down, it becomes very difficult to remember, or if people get new jobs and they come in, if things aren't written down, that becomes a real issue. So we created a referral protocol guidance. And then we also had to help clinics brainstorm solutions, about transportation, the dentist not taking Medicaid, or the dentist not wanting to see children, and staffing within the own clinic, like who's gonna do that? Because it was pretty time-consuming. And I'll get to some more specifics around our solutions in a minute. So we have this other project, which, at the outset we knew would have some care coordination involved, although we didn't really realize how much. So this project is CDC funded. We're partnering with the National Association of School Nurses and Advocate for Youth. They're our national partners, and this is about young men having sex with men. Their HIV rates are really high and terrible, and especially when you're thinking about African American and Latino youth. So we have been working in New York, Philadelphia, and San Francisco, and our primary site has been in New York. And again, this turned into basically a care coordination project in terms of how do you build these strategic partnerships. You would think in New York, there'd be all these services and everyone would know about it and it would just be really easy. People just, have a lot of work to do. And so in doing this work and getting people to work together, we heard a lot of, I haven't seen you in 20 years. And they might have been still in the same job doing the same work, but they hadn't had the time in their job to be allowed to go and work with other people. And so we were able to do that for them and to find out what are the new projects are and how they can work together in new ways. And again, the whole issue of documenting linkages of care. Somebody was asking earlier about, well, how does somebody know that you're not part of, this organization or whatever, and whether those things need to be written down, taking care of HIPAA, taking care of FERPA for schools is really important. And then creating shareable mechanisms. So especially with youth, we're making a written thing for the providers, but youth don't really, they're not really interested in that. So, whether there's a texting service that could be created, or whether there's something that's just easy, that's mobile on their phones, or, they could use the printed document. We're also talking about ways in which it could be electronic for the provider so it gets updated pretty frequently, because I'm sure a lot of you have gotten what seems like a really good document because somebody had, a grad student or a volunteer and they created a document and then nobody updates it. So the phone numbers are wrong, the addresses are wrong, and it's really not doing anyone any good. So we've been looking at ways in which, are people willing to do a Google document? Are people willing to do Dropbox? What are ways in which you know that it's a living document so that when you make referrals, you know that it's up to date? So staffing solutions. Really, this is sort of crowdsourced from the people that we've worked with our projects who were having issues with care coordination. They really felt like they needed somebody to be in charge of it. And their definition of charge could change, based on the different clinic, but they really felt like somebody needs to be in charge of the referral document. It needs to be somebody's job to make sure that the referral loops are closed. And it was sort of up in the arms about who that person was, whether it's a nurse, a social worker, a navigator, a community health worker. I put that 6-week curriculum because we have one on our website that it's like full kit and caboodle. It's really lovely. It was created, I think, out of Wright State in Ohio. And so if you're looking for a curriculum where you basically don't have to do anything, it has little quizzes, it has stuff for, the people who are coming, and then also for the people who need to lead the class. It's really comprehensive. Community Health Corps is also a place in terms of staffing solutions. It's like AmeriCorps, but it's just for health, and they're based out of Chicago. But people definitely felt like they needed to have somebody in charge. Now, the kind of concern that, we've had some clinics in Oregon who've used their AmeriCorps workers to do the care coordination, but they change, right? So they might be there 1 year, maybe 2 years at most. So if you're looking for some longevity, especially if you want somebody who's building relationships, that might not be the best solution. But it could be for you. And then in terms of documentation, everyone realized, even though they felt like they didn't at the beginning, that things needed to be written down. That a lot of services had started, whether there had been, that organization used to come and do HIV screening once a month for years, and then one day they just stopped. And, it's because people didn't know who was really in charge of that relationship. They didn't know whether they were doing it for free or if people were being paid. And so documenting the responsibilities is really important, even if it isn't in an official, contract or letter of agreement or memorandum of understanding, as another group was talking about before. So there are these opportunities with health insurance for us, in our projects. A lot of the issues had to do with access. And so we have the health exchanges are coming up, and HRSA has, unleashed a gajillion dollars on trying to help people get enrolled and with federally qualified health centers. And in the last one, although the application was due on the 31st, they were practically giving away $150 million to federally qualified health centers, and at minimum, they had to employ at least one FTE for this outreach and enrollment, because, a lot of people, things change, and so that was really helpful, and we really wanted, especially for the school-based health centers, that if there were kids who were uninsured, maybe the kids could qualify, but, oftentimes the parents didn't know that they could qualify themselves. They just had thought that there were barriers that didn't exist, and so it's helpful to have somebody evaluate for them. I wanted to show the telephonic signatures, because in ACA that they'll require those in 2014, and apparently that's been around for a while, where basically, and I put this hyperlink in there so that you can go there, but there is, they will accept a signature via the phone. So, and that will enroll people in Medicaid. And apparently the software has been around for a long time, and CMS has approved it. And this website will show you some case studies on how it's worked, but it's gonna be required in 2014, and I think what would be really great about this is that if then the telephonic signatures could be used in other ways, not just to enroll people in Medicaid, but could be used, especially because we're dealing with minors, if we, the parent has to give the child consent to be seen in the school, but even when the child comes in and needs something, we're still calling the parent, but if something additional needs to have happen, they fell, and we want to splint something or whatever, it would be really nice if there's this formalized telephonic signature. So I wanted to put that up in terms of sort of more to follow. But I'm sure a lot of you want to know, do you really have to reinvent the wheel? Does somebody already written this stuff down that I can just copy and paste? And yes. So I have up here several copies of a tool that our Director of Research and Evaluation made, and it's just 2 pages, so it's not super lengthy, but it's something that you can take, and I modified it a little bit for this purpose, but it's what she used to go into different clinics to evaluate what were factors that drove good care coordination, and then factors that were barriers to care coordination. And so there, you can talk about your sponsor agency, is there a staffing model, do people know about your clinic? And so it's pretty open-ended, and so it's not really directive, but I think it would be a really good tool for you to use to evaluate yourself on what you could do and kind of create a plan on where you wanted to move forward. And I can send it to you electronically as well. And then the other thing that I have up here is, I think I do, the referral protocol guidance. So this one up here is just around oral health, but you really can't swap out oral health for almost anything else, because it's really about, where it says identifying the student need, you're identifying, the patient's need, your adult's need, and kind of walks you through, for somebody who's never done this before, what you need to think about in order to create a very specific protocol for your clinic. And then we also have this Linkages of Care guidance, which I brought for you in case you wanted it, which, a lot of it is you're referring to different organizations, or you want the organizations to come and work with you. So, so for example, when somebody this morning was talking about the summer food program for the students, it might be nice to have it written down about how you're going to create that linkage with that organization. Who's going to be making the food, who's going to be delivering the food, just so that it's written down, because again, that's what we found is really important. You're going to do this for a summer, and then you might have new staff, and then next summer, no one's going to remember how to do this again. And then I also have here have organizational linkages, and I can send this to you, where it's basically the booklet that you would create for yourself about, you would put in, in terms of health services, who in your neighborhood, who in your city, provides these services, the name of the organization, the location, the services provided, who the contact person is, the contact information. These things are, again, just something that we created for our clinics because people didn't have time to make them, and it was preventing them from moving forward. And so, so I have them here to share with you, either in paper format or electronically. So care coordination and quality, and how do they really come together? Well, we've got core measures, right? So we've got the CMS, has adult core measures, and they have child core measures. And so, for example, care coordination totally shines when it comes to the receipt of the specialist report. So somebody has a stroke, right? And they go to the hospital, and then they get discharged, and they have specific instructions from the neurologist who saw them. If you show that they're in the community, that you received the specialist report and are engaging them in these activities, if you are, I don't think that this is technically if you're the patient-centered medical home, but it would make more sense, obviously, if that's the case, but that this adds to the core measures, right? So you count, you get credit for that. And then again, medication management for people with asthma. This asthma is for both adults and children. This is a really great way for care coordination to shine. And so this is a way, if you have a relationship with an FQHC, you could be improving their core measures, which they would love. And so maybe they would give you more money because you're working hard for them to look good and improve the health care of the clients that you serve. Another way that care coordination and quality connects is, again, that you can track the receipt of services. So the receipt of services, did Helen go to dialysis? Did Susie go get the CAT scan? Did somebody go get the mammogram? Did they get the HPV vaccine? These are the things that care coordination can help with, and it shows up in this data that everyone is obsessing about. There's actually Data Palooza going on right now in DC, and they are there just like having a good time about how can they track all this lovely data that care coordinators can help upload into the system. So there's the 30-day risk standardized readmission measures. And so the ones with the 1 asterisk talk about those. So you are there to help with, the heart attacks, the heart failure, the pneumonia, because the hospitals are going to get penalized when they come back in this 30 days. So again, this is how you can show up in the data in terms of the care that you're providing. And then the ones at the bottom with the 2 asterisks are from the National Voluntary Consensus Standards of Patient Outcomes. It's a pretty long book, but again, the asthma admission rate and the number of school days missed to illness, which I think is helpful and is interesting. So you can be providing their care coordination across the lifespan there and show up in data and get credit for it. And then the best part is when you've done such an amazing job, they retire the measures, right? So when people have been tracking something for such a long period of time and you do really well on your benchmarking, then they just put them to bed and they say, we're doing a really good job. Somebody was talking about how people pick up measures and then they move on to another thing to work on, and then the first thing that they worked on fell by the wayside and those outcomes look poorly. But here you're showing that you can really focus on different things at the same time, and things are continuing to be good, and then you can retire those measures because your clients are doing fine. Now we're going to have a quiz show. Please feel free to shout the answer. So somebody said this first thing in the morning. What makes up the triple aim? Starts with a C, one of them. Maybe another C, another one of them. Cocktails are coming. Care, health, and cost. So care coordination totally eats us up, right? We're all about the care, we're all about the health, and we're really good at decreasing the cost. And, and the people who deliver these services, I think, should really get the credit for it. Because what happens a lot of time is that you're saving other people money, and they're super happy about it, but you don't get compensated for the money that you're saving other people. And so I think that it would be great if you could get some of this money so that you could either break even or increase the services that you provide. Okay, so American adults experience, right? No. They receive recommended care only X% of the time. So what percentage of time do you think that adults get the recommended care? Louder, I can't hear you. E, somebody says 20, somebody said 42, somebody said 31. Anyone else? 50% of the time. But you're gonna fix it. Sweet. So then American children only get these services, the recommended services, what percent of the time? Somebody says 60. We got another number? 55, another number? Can't hear you. 50? 31. Okay, let's see. Oh, nope, not 31. 42% of the time. But again, y'all are here to fix it, right? You're going to improve these numbers so that when I'm here next year, it's going to be like 90%, right? All in 1 year. Okay, so following up with patients is easy. Ta-da! See, you knew. Follow your intuition. Okay, so care coordination is a billable service. Somebody says true, somebody have another answer. Somebody says false, somebody have another answer. Somebody says, I don't know what the other answer is. Sometimes. So depending on how your clinic is set up, you can get paid if you're already a patient-centered medical home, depending on your state. You can get paid for the services. Starting January 1st, there were new CPT codes that were opened up that will pay for transitional care management services. So if you have a lot of clients that are coming in and out from the hospital into the community, you can bill them, or you can look into, if you can bill, for 99495 and 99496. And then you can also look to see if you are able to bill for targeted case management, because it depends on your Medicaid state plan on whether or not you can do that. Okay, so care coordination and case management is the same thing. We've got a false, we have a true. Sometimes. It's a good thing, yeah. All right, we've got false. Okay, so I'm actually not going to have you shout this because this will get messy. There were too many words. So it's the system, sector-based, the agency, and then the client and family-based. And then, why is focusing on care coordination important? Right? Do you think it's because it's a professional development tool for staff and improves health outcomes? It's part of your mission. B, all of the above. All right, let's see. Oh. Ta-da! All right, so what is true about care coordination regardless of setting? Any takers? That it's easy, that Oprah will show up? No? Teamwork. All right, well, thank you so much for staying this whole session, and does anyone have any questions? Nope, everyone's ready for the cocktails? Me too. Great, thank you so much.